Our next speaker is Driss Raissi. Driss is another member of my training program in interventional radiology. Driss is a board-certified internist who is now studying diagnostic and interventional radiology. Among the most challenging components of the procedure is aftercare, and anticoagulation is a very important component of that aftercare. There are as many methodologies and practices for anticoagulation as there are people doing the procedure. I asked Driss to make some sense of it for you, because anticoagulation, in my view, is an important step in the treatment that extends outside the procedure room and is a key element in the initial phase of treatment after discharge from the clinic. Driss?
All right. Hello, everyone. My name is Driss Raissi. Works very closely with Dr. Sclafani at the university, and I was invited today to give a talk about mostly anticoagulation. So it's mostly going to be discussing the basics very quickly and the current anticoagulation armamentarium that we have and the very, very near future. I have no disclosures. Okay. Hemostasis. Hemostasis is the process by which the blood vessels, when they get injured, they'll try to make sure that you don't bleed. The process begins usually by blood clot formation at the site of vessel injury, followed by the coagulation cascade, and at the end, everything gets recanalized by fibrinolysis. The clotting cascade, very complicated. I don't really want to go through it. Most physicians don't understand it very well unless you are a hematology expert. Usually there's extrinsic and intrinsic pathways. No need to discuss the intrinsic pathways, as that's mostly for inpatient care. Extrinsic pathway is very simple. It begins after injury of the blood vessels, either by just getting a wound or simply from angioplasty, which is the main issue that we're discussing here. The angioplasty damages the blood vessel to a certain level, exposes the tissue factor. The tissue factor forms a complex with factor 7. 7 forms another complex, activates factor 10, and it keeps going on. And it's very complicated, and the main goal is to activate thrombin and form the clot. Thrombin is very important as it is the final enzyme of the cascade, and therefore it's the ideal target for most anticoagulants. This is the coagulation cascade. I'm not going to go over it. Very complicated. I can never remember it. But as you could see, the extrinsic pathway near the tissue factor, which is basically the blood vessel which is injured, factor 10 is one of the main factors in the cascade. Okay, so the first drug is one we know has been around for a long time. We know it very well, well studied, heparin. But it's a big molecule, not very specific, which so it has its drawbacks. It's an indirect thrombin inhibitor. It activates antithrombin, which is a natural enzyme that we all have, but it's sleeping in most of us. So you need to activate it 4,000 times, which is what heparin does, in order for it to inactivate thrombin and make sure that we don't clot. Inactivate thrombin and other factors. As I mentioned, heparin is not very specific. Heparin is well studied, safe in pregnancy. It has a very narrow therapeutic window, and it requires frequent, every 4 to 6 hours, monitoring of the PTT or the activated clotting time. But it does have a very variable anticoagulant response. From my clinical experience myself and from the experience of many people, the Extract-TIMI 25 study, which was published 2 years ago in Circulation, showed that only 34%, this in hospitals with very good protocols, only 34% of patients showed on initial testing with PTT were therapeutic. So basically, more than 60% of the patients for the first 4 to 6 hours were simply non-treated. A potentially deadly complication of heparin is what's called HITT, which is heparin-induced thrombotic thrombocytopenia, which is basically massive clotting all over the body, which could potentially lead to death or very severe multi-organ failure. It also requires platelet monitoring initially, especially if you are on it for more than just intra-procedurally. These are some of the common indications for heparin: venothromboembolism, VTE, prophylaxis, and also there is a therapeutic dosage, which is usually based on many normograms. My favorite is the American College of Cardiology normogram, or simply don't even think about it and use 100 units per hour IV and just monitor from there. It works pretty well. Good things about the drug is if you don't know what you're doing or something happens and a patient is anticoagulated and you need to interrupt it, you can, and it works very well with protamine sulfate with a ratio of 1 milligram to each 100 units given of heparin. Protamine sulfate is a pretty safe drug with only allergic reactions as a side effect. Mostly the most common adverse effects of heparin are skin necrosis, osteoporosis only for long-term use, and HIT, which is a milder version of HITT, or HITT, as I mentioned, which could be potentially deadly. Mostly it happens after 5 to 10 days of use. The other newer generation, not so new anymore, the lower molecular weight heparins are pretty much just a smaller molecule of heparin. Heparin is a very large molecule. They took heparin, they depolymerized it to a smaller molecule of heparin, to a smaller molecule, which makes it more specific. So it doesn't really inhibit everything that you could see on the coagulation cascade. It mainly targets factor 10A with a much less effect on antithrombin. But the drawback of that is you can no longer monitor it through the PTT. Something to know about it. It is injectable. So so far now, it's not a very expensive drug. It's moderately priced, but it is injectable. So if you're not willing to inject yourself, you might not like it. It might require some nursing care at home. So that's one of the drawbacks. It's class B in pregnancy, which means no data, but unlikely to cause harm. Advantages: it has great bioavailability subcutaneously, which is the main form of injection. It has a very long half-life, especially for enoxaparin and tinzaparin, allowing 1 daily dosage. The dose correlates very well with body weight, so no need for normograms, no need for lab monitoring, another thing. Although you can do it, theoretically you can. It has 20 to 30 times less risk for that potentially side effect, potentially deadly side effect, HITT. It's safe as an outpatient, and it has less risk of long-term use-induced osteoporosis. All right, vitamin K antagonist, that's aka warfarin in the United States. Acinocumarol is mostly used in Europe. Long half-life, basically vitamin K antagonist, as their name indicates, aka warfarin, inhibits factor 2, factor 7, 9, and 10, which are the synthesis, which are the vitamin K dependent factors in the liver. It also inhibits the activation of protein CNS, which is not really something that you're looking for. As protein CNS, we all have protein CNS, and it's a natural anticoagulant. So initially, the inhibition of protein CNS could make you somehow prone to thrombosis the first 2 to 3 days. That's why warfarin needs to be overlapped immediately with heparin for the first 3, 4 to 5 days until you reach a therapeutic INR. Warfarin is water soluble, 100% bioavailability, but cytochrome P450 dependent means cytochrome P450 is one of those super mega enzymes in the liver that break down all the drugs that we take, detoxifies you. So the fact that warfarin is cytochrome P450 dependent means that it's dealing with a lot of things at the same time. It's trying to stop warfarin, it's trying to stop other drugs. P450 dependent cytochrome makes warfarin very prone to multiple drug interactions. So polypharmacy could be a huge issue. Another thing, it's urine excreted. Currently undergoing trial is something called ticafarine. Hopefully we'll hear about it in the future, which is a vitamin K antagonist, basically like warfarin, but without the bad things. It's not P450 dependent, it's not susceptible to drug interactions, nor food interactions, nor genetics. Because warfarin is susceptible to all of those. The initial therapeutic INR, the first 2 to 3 days, you see that the INR is increasing a little bit. 1.6, 1.7 reflects the depression mainly of factor 7, which has the shortest half-life of all of them. But 2, 9, and 10, the other ones, remain relatively unchanged, which means that you are still not fully anticoagulated, and you must be overlapped with heparin on some form of other immediately acting anticoagulants. Genotype testing has been developed for the last 6 years, CYP2C9 and VKORC1. These patients who are carrying these genotypes are extremely sensitive to warfarin, and they need to be on a different normograms. And this is much more common than we think. It's, as I mentioned, is monitored by the PT or /INR. What is the INR? The INR basically is a standardized formula using a specific PT prothrombin time for that lab. The influence of dietary vitamin K. It's something that really matters to your lifestyle. It could really change your lifestyle and more than we think. The threshold for lowering the INR is only 150 micrograms of vitamin K. And to give you an example, 1/2 a cup of spinach has more than 500 micrograms of vitamin K. So you can see the impact of diet on warfarin metabolism. Luckily, we have a reversal agent, which makes it sort of safe, either with vitamin K, parenteral vitamin K, oral vitamin K, or fresh frozen plasma. So this is my favorite normogram, and it basically shows you that you really need to take care of, when you start a patient on warfarin, you really need to stay on top the first week, the first 10 days. You can't just give somebody warfarin and see him in 2 weeks. You need to watch where his INR is trending toward and modify it the 3rd day, the 4th day, the 5th day, depending if it's increasing, not increasing, decreasing. You get the picture. You can't see this slide very well, but it's basically just to show you all these foods have a decent level of vitamin K. Vitamin K that's gonna jeopardize your INR, and it's all interfering with warfarin. And mostly the green leafy greens, which at the top, which you can see they have like enormous amounts of vitamin K. Adverse effects. Look at this list. I mean, basically everything you could imagine for warfarin can cause it. Every sensation you do, every rash, it can be warfarin. It is possible. Vasculitis, coma, dizziness, fatigue, from mild alopecia, mouth ulcers, anything you could imagine, it could be a side effect of warfarin. Okay, fondaparinux. It's one of the newer agents. It's a synthetic pentasaccharide derived from heparin. It activates antithrombins and activate factor 10A. You can see that we're always talking about the same factors here. It does not interact with platelets, which make it theoretically safe for patients with history of allergy to heparin or previous HITT. It's pregnancy class B. It has a long half-life, sort of, 17 hours, which allows once daily dosage. 100% bioavailability subcutaneously in 2 hours. And you can see the different dosages depending on prophylactic dose or full anticoagulation dose, which is weight-based. And it correlates very nicely with the patient's weight. It may be monitored via factor 10A level, very expensive assay. Not really done because most of the time it's not really necessary. Can it be reversed? Yes, it can be, partially, with factor 7A and super expensive, thousands and thousands of dollars, recombinant factor 7A, if needed. The double-blind Mattis trial did show that fondaparinux was as effective and safe as lower molecular weight heparins, and the FDA approved it. The risk of HIT is perhaps very low, or some people say controversial, some people say non-existent since it's derivative from heparin. But in my personal experience, I've treated patients with HITT with fondaparinux with absolutely no issues. Idraparinux, it's a drug that it's not really known because during its development it was halted. It was intended to be, one of the best drugs out there. Once, can you imagine? Once once a week injection. That sounds pretty good. Once a week injection. But a lot of my colleagues were very worried about reversibility. We didn't have any reversible antidote to it. So basically they stopped it. They stopped its development, and now they're working on something very similar, which is ADRA biotiopyrinox, which is a biotinylated version. They added this molecule, biotinylated version, which is reversible with Avidin infusion. Phase 3 trials are currently underway. It could be a great drug, once a week injection. Can you imagine? Let's talk about another group, the direct thrombin inhibitors. Mostly, these are anticoagulants that will be used intraprocedurally. They're in the procedure because you can only give them intravenously. Argatroban, Hirodin, Lipirodin. Hirodin initially was derived from the leech salivary gland, but Lipirodin and Argatroban are recombinant versions of Hirodin. The absence of binding to platelet factor 4 makes it an ideal drug for HITT patients or patients with allergy to heparin, to make it more simple. It has a wide range of clinical approvals, which suggests a certain level of safety and comfort in using it. It's monitored either with PTT or the activated clotting time, and it's overlapped with Coumadin because, as I said, it's only intravenous, so you'll have to be started in Coumadin. And the INR, the recommended INR to stop it is when you reach an INR of 4. Just to have a general idea, bivalirudin is my favorite drug intraprocedurally. Half-life of 25 minutes, which makes it ideal for PCI. And I personally use it intraprocedurally for patients who are allergic to heparin, mostly in dialysis ward. Lepirudin is the ideal drug for patients with liver problems, and Argatroban will be the ideal drug for patients with renal issues. Dabigatran, very exciting drug. Pradaxa is its commercial name. It's an oral direct thrombin inhibitor. Peak effect in 2 to 3 hours, which means you don't need that initial heparin, unless maybe the intraprocedural, or maybe you can take dabigatran before your procedure. Peak effect in 2 to 3 hours in an oral agent is pretty amazing. It has, again, you could see a wide range of clinical approvals. Half-life of 12 to 14 hours, allowing twice a day administration, renally excreted. You have to be careful with patients with moderate renal insufficiency. The RECOVER trial, which is a double-blind study with more than 2,500 patients, showed non-inferiority of dabigatran compared with warfarin in VTE. The RELY trial is another trial that showed superiority to warfarin in stroke and AFib prevention with less major bleeding. Why less major bleeding? Because it's a more specific drug, specific at the molecular level. It does have an FDA-approved dosage for patients with moderate renal failure. Adverse effects of dabigatran will be mostly dyspepsia, gastritis, bleeding, abnormal LFTs. Most of them, I reviewed all of them, and nothing seemed to be, it seems to be a pretty safe drug. Clinical trials ongoing. Apixaban is actually approved in Europe, but in the US it's still undergoing more clinical trials. It's an oral agent with promising results in phase 3 trials, as I mentioned here, as compared to warfarin and enoxaparin. It's less dependent on renal function, and there's no reported hepatic toxicity. Rivaroxaban, Xarelto, is, to me, very similar in profile to dabigatran. It's an oral direct 10A inhibitor, 100% bioavailability. The elimination half-life is 5 to 9 hours, which, if you raise the issue of, we don't have an antidote, but the elimination half-life is pretty fast, so it shouldn't cause a problem. Trials did show a non-inferiority to lower molecular weight heparin in VTE therapy and prophylaxis. Rivaroxaban does not require initial heparin administration. So again, like dabigatran, you don't need to give heparin initially, as it peaks in 2 to 4 hours, very fast in an oral agent. The 2009 RECORD trial, more than 3,500 patients showed superiority versus enoxaparin in DVT prophylaxis and in the treatment of warfarin in patients with AFib. The 2010 Einstein group published in the New England Journal a randomized controlled trial showing non-inferiority to enoxaparin followed by warfarin in the treatment of DVT. Similar bleeding complications were reported with enoxaparin and rivaroxaban. It's cheaper than lower molecular weight heparin because it's administered orally mostly. I think it costs $8 a day. the FDA did approve it in the US for orthopedic surgical prophylaxis for hip and knee surgery. Overall, the review shows that it's safe. Mostly the risks are allergic dermatitis, abnormal LFTs, which is, liver problems, nausea, but it does contain lactose. That's an interesting thing for all those lactose intolerant patients. Antiplatelet agents, this is a very quick review. There are many antiplatelet agents, mostly the ones you should probably be familiar with, which is aspirin, clopidogrel, aka Plavix, ticlopidine, dipyridamole, and prasugrel are the ones you probably should know. Prasugrel is known as Efion, is the newest kid on the block, strongest, fastest, very promising, used by our colleagues in cardiac cath. Ticlopidine, Plavix, and prasugrel are they all belong to the same group, so if you're allergic to one of them, you're probably allergic to the rest. Dipyridamole has a vasodilator effect with good data for secondary stroke prevention. Some patients are genetically resistant to aspirin and Plavix, so that you should probably know this possibility. Clopidogrel, aka Plavix, is also associated less than 1% chance of causing TTP, which could be deadly. Prasugrel does not have any reported cases of TTP. And also, so many people these days take PPIs, proton pump inhibitors, such as omeprazole. And Plavix is known to decrease the effect, PPIs, I'm sorry. Omeprazole is known to decrease the effects of Plavix. But there is nothing reported about that, about prasugrel, Efion. So just to show you all these antiplatelet agents acting on different receptors on the platelet. Some of them are irreversible, some of them are reversible inhibition of platelet activation. So why are we talking about all of this? Anticoagulation, antiplatelets, well, because of angioplasty. So I'll show you a cross-sectional imaging of a blood vessel. You can see the endothelium is the innermost layer of the blood vessel, which will be the layer that will get injured during angioplasty. That's the only way to do angioplasty. So that inner layer is essentially a thrombolytic layer. It hides that tissue factor that I mentioned earlier, and by hiding it, you don't form a clot. But immediately following angioplasty, you injure the endothelium, and there is platelets and leukocytes, white blood cells, who will be recruited to form a plug, but that could cause thrombosis. Endothelial injury from angioplasty is associated with many consequences. Most of them are just trying to repair your blood vessel and stop you from bleeding, but that can make you clot, essentially. So the data out there's not much data. You can't really do the studies in patients in general. So the animal data shows that immediately following angioplasty, these endothelial cells start replicating. They get activated by all these factors, fibroblast growth factor or VEGF, which is a vascular factor, and tries to reparate from the edges towards the center. And the process begins immediately within the first 24 hours. And in animal models, has been shown to stay going on for 6 to 10 weeks. In humans, there is very limited data, obviously. Examination of some specimens have retrieved later do suggest that the re-endothelialization process may last anywhere between 1 and 5 months, which means you may have to be on anticoagulation or antiplatelet therapy for that long to protect yourself from thrombosing. There's no prospective studies evaluating the need for anticoagulation or antiplatelet therapy in venous stenting. Most of the data is from cardiac cath, from coronary stenting. And it is shown, proven, and accepted today after many trials that dual antiplatelet therapy is superior to antiplatelet therapy, to anticoagulation therapy alone, or even anticoagulation therapy plus aspirin after coronary stenting. The American Heart Association and ACC does recommend 12 months minimum of dual antiplatelet therapy after coronary stenting. So this is something important, but although some experts do advocate lifelong therapy after stent placement. So what can you do? Since there's no data out there, well, use common sense. Number one, you weigh the risks and benefits, individualized therapy. You can't just treat everybody the same. You have to think, think about the bleeding risk for each patient. You could use several bleeding risk scores like the Hasbled or the OBRI, or you could just do common sense. Common sense tells you that older than 65, history of stroke, history of GI bleeding, very anemic, recent cardiac infarct, probably is a patient that you should be very careful with and stay away from anticoagulation. Hey, I'm an internist. If you consult me, I will tell you something that's based on the data out there. And I will recommend dual antiplatelet therapy after angioplasty. If it's after angioplasty, 1 to 3 months. Most of the data is from cardiac cath. 6 to 12 months is recommended after stenting from cardiac cath. But I would recommend that in veins. But again, I repeat, you have to weigh your risks and benefits. Mostly dual antiplatelet therapy is slightly safer than full anticoagulation. Anticoagulation, that's very tough thing to say. 7 to 30 days post-procedure, there's no clear evidence. You have to weigh the risks and benefits again. There's different cocktails that you could consider. Intraprocedural anfraction heparin, that seem to be safe. And then you can decide to either convert to low molecular weight heparin or fondaparinux, then warfarin. Warfarin does seem to be very complicated to take care of unless you're very highly motivated and you go to a dedicated warfarin clinic. Dabigatran and rivaroxaban seem very exciting drugs that you could take immediately after the procedure. They don't require any monitoring at all, and they sound very exciting drugs. So my advice, well, now your options, stay informed, take responsibility of your healthcare, communicate with your physician, and you are your #1 advocate, and don't be shy. Thank you.